So. Everybody hear me okay? I'm David Hoyt. I'm the Executive Director of the American College of Surgeons, and I want to start out by thanking everybody for coming this morning to the first Chicago Surgical Healthcare Quality Forum. We started an effort about a year and a half ago to really better understand our quality programs and reorganize the way in which we put these forth to the public. And we've decided to have a formal launch or a formal campaign around that topic. And today is really the beginning of that launch. We're privileged to have a number of leaders from the Chicago area that will participate in our forum. And it's my privilege really to try and set this up for you in terms of context and go through a brief summary of the college programs and why we are here today. Now, the Aspiring Quality Initiative is really our attempt to have particularly the public understand that at our core, education and a devotion to quality in patient care is our core mission. And what we want to spend some time today talking about is why this matters. Why is this important? Why is this really essential for healthcare reform? Now, it turns out that at a national level, we have, for the first time, in my belief, true alignment with our focus on healthcare reform. The National Strategy for Quality Improvement in Healthcare put forth by Secretary Sebelius' office this last year focuses on improving care, improving healthy people and communities, and making care affordable. So those are the three pillars of that improvement strategy. Similarly, CMS, through the Triple AIM initiative, has a set of goals of improving the experience of care, improving the health of populations, and reducing per capita costs. So between the two major agencies in our federal government, we have alignment in terms of goals. Finally, the Institute of Medicine, which is really the large think tank for healthcare in the United States, put forth a concept of a learning healthcare organization 2 years ago. And I want to frame for you why the programs of the American College of Surgeons fit into this concept very nicely. Now, having said that, in fact, our legacy in the college is to be involved in quality improvement. And this goes back to our origins in 1913 with the establishment of the Clinical Congress, which was focused on education, the initiation of the minimum standards for hospitals in 1917. This evolved into what we now know as the Joint Commission. In 1951, it spun out of the American College of Surgeons and became an organization unto itself. And we're fortunate today to have Dr. Mark Chassin here with us to talk about that effort. In addition, we've developed the Commission on Cancer, which certifies cancer centers throughout the United States. The Committee on Trauma develops standards for trauma centers. And over the last several years, we've developed programs in clinical trials in cancer, breast center certification, and bariatric surgery certification. The newest program, and the one that we're going to talk about most specifically today, is the NSQIP program, or the National Surgical Quality Improvement Program. And this is really a database that measures effectiveness of care and quality of care and allows hospitals and individual surgeons to evaluate their outcomes against national standards. Now, through all these efforts, we have come up with 4 primary principles that guide continuous quality improvement. And I want to just go through these because these are the bedrock of our commitment to patient care. The first is to go through a process of evidence basis based on research individualized by patients to set standards for care, whether it's standards for breast surgery, standards for a trauma center, standards for a cancer center. We go through a process with our fellows to establish what the appropriate standards of care ought to be. The second is then to define and put in place the right infrastructure in a hospital, in an ambulatory environment, including staffing levels, the right mix of specialists, the right equipment, having the checklists in place to actually perform to these standards. The third principle is to then measure your outcome. Look at, if you will, your actual performance using rigorous data that comes from a medical chart. It's backed by research, and it's continuously updated. And then finally, external verification, peer review, the use of external peer review to validate, to assure the public that what we say we're doing, we're actually doing. And these four principles are really embedded in all of our programs. Well, I want to just end my comments with an example, a very concrete example based on the NISQIP program, and you'll hear more about this from Dr. Coe, but it's really one of our most important programs from the standpoint of creating a tool that allows a hospital or an individual surgeon to improve. Now, what you see on this slide is called a caterpillar diagram. It's really plotting the expected to observed ratio of a particular hospital, or it even could be a particular surgeon, against some outcome. So that line labeled 1 would be the normal, if you will, infection rate or some other complication rate for a patient following surgery. And what you then see is each line represents a hospital's performance relative to that line. So that on the right of the slide are people or hospitals that are performing worse than you would expect. And on the left are hospitals that are performing better than expected. Now, what is the natural tendency of all of us when we get performance data about our performance on something? It's to try and improve and get better. And that is the power of this kind of program, is that if a hospital participates in this and they see themselves performing less than they would expect, and you're going to hear examples of that today from very, very good providers or hospitals, that they found something that they were doing that was not quite as good as they wanted to do, and they used this data to then improve. That's the power of this. Now, if you look at, does this actually happen? That's the theoretical advantage of it. The study that you can see on the right of the slide there is looking at 112 hospitals over a 3-year period and using this database and then evaluating how the hospitals changed. There was a reduction in complications of 82%, a reduction in mortality of 66%, and that averaged out to about 1 complication per hospital per day. 1 complication per hospital per day. It's not huge, but actually it is. If you look at the cost of a complication and attribute about $10,000 to a complication, and you spread that ability to reduce complications by 1 complication per day per hospital across the United States, you're talking not only about improving care dramatically, but about saving a tremendous amount of money, literally billions of dollars. So again, to summarize why we're bringing this to the public today, why we're launching a campaign, why we're recommitting ourselves to this effort, is because we really have a way to bring improving quality care and lowering costs together. And the programs you'll hear about today from the American College of Surgeons are focused on this effort. And it's led to this concept of an Inspiring Quality campaign. Well, we have a panel of experts today, and they represent some of the most committed individuals in the Chicago area to surgical care. And we are expecting Senator Mark Kirk as well to join us, and we'll just sort of adjust the program when he is able to arrive. But to start out, I want to introduce my colleague, Dr. Britt, and he is currently the president of the American College of Surgeons, and he's going to make some opening comments as well. Dr. Britt?
Well, thank you, Dr. Hort. I want to first recognize and thank Dr. Hort And Dr. Pellegrini, Dr. Carlos Pellegrini, who couldn't be here, is the chairman of the Board of Regents. The Board of Regents is our governing body, major governing body, because they've been the two principal architects for this. I also want to recognize the senior staff. I want to recognize Lynn Meyer for her strong work in orchestrating this program. And I also want to recognize Nancy Longley and the Weber Stanwyck group for obviously providing the infrastructure and all the components to make this successful. You know, as president of the college, I've had a chance, and Dr. Horton and I just got back from Thailand, but I've had a chance to travel throughout the world. And what has struck me is the tolerance, which is fine, for extremes. The global society has a tolerance for extremes in wealth. They have a tolerance for extremes in material possessions, even education. Even whether or not who has sterile water, there's a tolerance of the disparities between those two, the haves and the have-nots. Even in our country, we've created a little bit of a tolerance there, but what we can ill afford to do is to tolerate disparities in quality. The college started that way with an emphasis on quality. There's no way that we can have different cohorts of patients getting different degrees of quality. And that's the whole emphasis of this forum. Because the college, again, you go back 100 years, 1913, the whole emphasis was not on how to advance the profit. The whole emphasis was on what can we do to have quality surgeons, quality techniques. And as Dr. Hort highlighted, the Joint Commission is an outgrowth of the American College of Surgeons. And so this meeting is about defining quality, in my opinion, ensuring quality, and now we have this campaign for inspiring quality. And so I'm very proud to be part of this. We have a distinguished panel. I call it the Greater Chicago Experts, the Chicago surgical community. And we have experts in the audience. And so hopefully we'll have an intellectual exchange. If not, I have a lot of questions myself, if no one asks a question, but hopefully we'll have a good exchange. And so what I would like to do is turn over to Dr. Hort to introduce our first speaker. And again, when the senator comes in, then we'll obviously modify the session. Dr. Hort?
Right. Thanks, Dr. Britt. It's really a pleasure for me to introduce Mark Chassin, the president of the Joint Commission. I've had a chance over the last 18 months to develop a relationship with Dr. Chassin, which has been certainly about our combined efforts in quality, but also as a friend and truly a mentor. Dr. Chassin oversees the activities of the nation's preeminent standard setting and accreditation body in healthcare, the Joint Commission. He also was the founder of the Joint Commission Center for Transforming Healthcare, and we have partnered with them in that, which he'll undoubtedly talk about. This center is looking at safety and quality in such healthcare problems such as surgical infection, handoff communication, wrong site surgery, surgical site infections, and preventing avoidable heart failure hospitalizations. The center develops solutions by using the robust process improvement method, and then has developed tools to disseminate practice in hospitals that are participating. Previously, Dr. Chassin was the Guggenheim Professor of Health Policy and a founding chairman of the Department of Health Policy at Mount Sinai School of Medicine in New York, and he's a board-certified internist and practicing emergency medicine physician for 12 years. Mark, thank you for coming today, and we look forward to your comments.
Thank you, David. It's a very great pleasure for me to be here with you this morning. And just to be clear, I'm not a surgeon, but my father was, so I feel an even closer affinity to the college than I might otherwise. The Joint Commission is very proud of its long-standing relationship with the American College of Surgeons, as both Drs. Britt and Hoyt suggested, going back nearly 100 years to the creation of the idea that we should set standards for quality and then hold practitioners and providers accountable to them. This partnership has entered a new era with the increased emphasis of the American College of Surgeons on quality and the Joint Commission's emergence as a quality improvement organization. The partnership that we've created now with the college around the NSQIP program allows us to work together using the NSQIP data and using the Center for Transforming Healthcare's very effective process improvement tools to figure out exactly what it is about preoperative, intraoperative, postoperative management that explains these very wide variations that we see in risk-adjusted complication rates. And then when we find those discoveries, as we are with the center's projects, the Joint Commission's job is to disseminate those findings very widely to our 19,000 accredited organizations. So it's not just the individual organizations, hospitals participating in the projects that benefit, but the entire delivery system. So we welcome the opportunity to continue the evolution of this partnership between the college and the Joint Commission, making it stronger and making it work to improve healthcare across the nation. Thanks, David.
Thanks, Mark. Dee?
Yeah, our next panelist is Dr. Alejandro. I'm sorry. Oh, Senator Kirk. Oh, good, excellent. We'll start, and then obviously come to Dr. Perez tomorrow in a minute. Well, the United States Senator Mark Kirk has had a long legacy. He had 5 terms as the House of Representatives. He had obviously was elected during a special election to be the senator to fill President Obama's seat. Then he was selected again and won the election for a 6-year term. The reason why he's a household name, not just regionally but nationally, when you are on a committee on appropriations, also on a committee on housing and urban development, also on the committee for health, education, and labor, and on a special committee for aging, I think you cover the full spectrum. And the good news is that he's been a partner and supporter of the college. He recognizes quality and also recognizes the fact that quality can be cost effective. And so, Senator, we're happy to have you here, and again, welcome.
Well, obviously it's a busy time in Washington, and I've got to catch a noon flight to be on the Senate floor at 3:30 today. But I very much want to support the college and what it has done, and to touch on a few hot healthcare items that are coming up in the Congress, especially for August and then I think for December. As you heard, I've been a very junior senator for the state of Illinois all of 200 days now. But in my request to the leadership for appointment to committees, I picked a set of healthcare related committees because of how important it is in the patient's life of the 12.6 million people that I represent. And also because healthcare is such a foundation employer for the state of Illinois, with AMA, AHA, ADA, and others, all headquartered in the city of Chicago. And I was a former inmate of the American Hospital Association, so very much see it from the stresses and strains that this sector must survive with. As we go forward with budget deficits and debt discussion, healthcare is a major focus of what we're going to do. And my hope is to, over the long term, provide a vision for where we would like to go, which would provide more direct relationships between the patient and their physician, and fewer controls and bureaucratic interference by bureaucrats in Washington, D.C. I think the unfolding model that I would not want to follow is set by an organization ironically called NICE, which is the rationing organization of the National Health Service in Britain. Now, nearly all of us here, I would expect, have visited the United Kingdom, and generally people do not get on a plane and attend a conference or go on holiday with their families unless they're in good health status. But as someone who lived and worked in Britain for 3 years, it's quite a shock on your first visit to an actual British hospital. I think of St. Bartholomew's, one of the first public hospitals ever created, who went 800 years of continuous operation through the Civil War of England, the Reformation, the Blitz, and then when the NHS took over St. Bartholomew's, it took only 38 years to drive that institution into bankruptcy and to close it. Governments, by nature, are always out of money, as we see right now, both in the state of Illinois and in Washington. And how do we prevent that collapse of public finances from hurting patient care? And so the long-term vision, I think, for a growing bipartisan majority of us is to design coverage to cover catastrophic care at a $5,000 level deductible, and then have internal mechanisms to allow families to build up savings to cover the deductibles. This is something that we were told would never work when the 401k program was first put forward, and now we have 80 million Americans participating in that program. We also want to make sure that we're protecting patient care through legal reform. And here, the state of Illinois, I'm particularly worried about. We have seen, and this is, access to care is not a critical issue, for example, in the central part of the city of Chicago. But through the rest of the state that I represent in central and southern Illinois, we now have critical specialties missing from emergency rooms. And you all, as professionals, know about the golden hour in trauma care. And for many people throughout central and southern Illinois, they will not be able to see a competent ER specialist during the golden hour because those practitioners have been driven out of the state. This is extraordinarily common when you are in the hospitals that I have been in, south of I-80. Now, even the Democratic-controlled state legislature decided that this was a problem, and so we passed comprehensive medical malpractice reforms in our state. But Illinois is not a state like other states. When we look at our Supreme Court, men and women with distinguished backgrounds that wear judicial robes, we may make the mistake of thinking of them like federal Supreme Court justices who hold their office for lifetime appointments and then could upset whichever party might have put them forward. That's not the Illinois Supreme Court. The Illinois Supreme Court are politicians in robes. They are elected, and they respond to the dominant fundraising and partisan feelings of the state, which means they respond to the trial bar. And so the overwhelming bipartisan reforms put forward by the state were struck down by our political Supreme Court, which is why I have joined with Senator Blunt to back a federal malpractice reform that I hope that will move forward. Right now, the president will veto such legislation, but we have another election coming. And my hope over time is that we build bipartisan consensus behind a national malpractice reform, modeled after the success we see, for example, in California and especially Texas, where we've seen an outflow, I think, of doctors from Oklahoma that doesn't have such reforms, to Texas that does, offering better access to care, more choice of physicians, higher quality, and protections that we all deserve. One last thing. We're going into a discussion of deficits and debt, and we could either worsen patient care or improve it. I'm worried that we will continue to expand eligibility across the board for programs that have no money. And that's increasingly evident in the Medicaid system. Here in Illinois, half of all births are covered by Medicaid. And in that system, which is now seen as most highly stressed, most subject to fraud, our state legislature put forward a set of bipartisan reforms to help combat that. The reforms were estimated to return about $800 million in financial strength to the Illinois Medicaid system. We didn't change eligibility in any way. In fact, we didn't change eligibility even from what Rod Blagojevich did to the program. We simply said this: we want to make sure that we have enough money to care for low-income families who are residents. And by the way, I use the term residents specifically. Didn't use the word citizen. Residents of the state of Illinois. And so that we look at their income to make sure that they are at 300% poverty level or less, and we look at the fact that they are a resident of Illinois. This, Barbara Flynn Curry, leader of the Democrats in Springfield, and Patty Bellock, leader of the Republicans on this issue, came together. Governor Quinn signed this reform to help make sure that the Medicaid system had integrity. But in a surprising move, the federal government just overrode the Illinois Medicaid reforms. Once again, opened up the avenue for increased fraud and abuse and, quite frankly, loss of income and financial integrity in the program. And for a state that already sees a rapidly declining credit rating and inability to borrow at higher and higher prices. My hope is that we can make this reform possible, that we can then have a vision going forward of covering people for their highest catastrophic costs, but then providing the incentives for them to save up to the deductible limit. And then, should lifestyles and habits improve, hopefully a long-term end to smoking, the First Lady's quite appropriate focus on obesity, etc., we will have more and more seniors qualifying for Medicare at higher and higher health status levels, and then taking the balance of what they have saved over their working lives and just rolling it straight into their IRA for income and retirement security. It's a big job. There's a lot of working parts here going forward. We'll see if we see the big deal on debt and deficits, which I support. That's the bipartisan commission view, or a smaller deal go forward. If you don't want to get totally maxed out in stress and caffeine, I would suggest you not watch the debate as closely as others, because it will have a way of concluding itself about one day before the deadline, which would be Monday, August 1st. And with that, thanks for listening and allowing me to give a quick view on an update from Washington.
Thank you, Senator.
You bet.
Senator, I know you know this, but I'm concerned that maybe your colleagues in Washington might not know that quality equals cost effectiveness. You know, we're here today not to talk about making more money, profits, or anything like that. We're talking about advancing quality. Is that being heard in Washington, that quality can equal cost effectiveness? Dr. Hort did a wonderful job talking about cost reduction. With limiting errors. Is that being heard in Washington, D.C.? They asked me to ask you the tough questions because I'm not from Illinois. I'm from Virginia. I would just say that largely not. Okay.
Almost every decision in Washington now is being made in reference to the collapsing credit of the United States and the potential inability for both the state of Illinois and the federal government to borrow money over time. At that point, quality is sacrificed, which is where the long-term need for the medical sector is to empower Americans to have insurance products that take care of their upper-end needs, and also empower them to save and invest on the model of the phenomenally successful 401k program, so that their health care does not depend on financial support from a bankrupt entity. I'm worried over time that we will go in the direction of Britain, in which a whole range of therapies and services are denied by the natural reaction of a bureaucracy, always to be against what is new, always to resist any change in care. And so to freeze health care in the decade of which the comprehensive regulation is put in place, which for Britain is the 1960s and for the United States would be the 2010s.
I'm glad you said that, because I just spent some time in Great Britain, and I agree with you. What should the college, the American College of Surgeons, the world's largest organization for surgeons, as you know, what should we do to bring this point home more in Washington? What would you advise us to do?
Speak clearly, make some tough calls. If the college votes 51-49, that's a decision. And then have any impact you can on the AMA, which is an utterly politically correct organization that swings with the political winds. Okay. And patient care should not swing with the political winds. Patient care is patient care.
One last question for me. You realize, because I know you're a student of this, that part of our quality comes in with our trainees, our residents, our interns. And there's talk about cutting graduate medical education, which I think will be a major problem of biblical proportion as far as maintaining quality. What is your understanding about trying to cut GME funding which is so pivotal to quality care, in my opinion, as an academic surgeon, to obviously ensuring quality.
Right. I support graduate medical education. I've been on all of the letters, especially support GME on the pediatric side because it can be underrepresented in a system overwhelmingly funded by Medicare that cares for seniors. Also, though, part of my job as a young senator is to be clear, concise, transparent, and tell you not what you want to hear, but what you need to hear. And I have said to everyone depending on federal funding, expect a 10 to 20% drop over the next year in funding. By the way, that's only half of the cut we need to make, because 40 cents of every dollar we borrow from China and abroad in an utterly unsustainable way. And over time, our ability to borrow more is being called into question. And so for those depending on federal funding, I just talked recently with the comptroller of the Defense Intelligence Agency. And they put forward a plan to run the agency at 80% of last year's cost. And I told them, on that basis, then, all the news you hear from Capitol Hill will be good, because it will be above the 20% cut level. But there are many lobbyists and special interests somehow projecting business as usual and laying forth plans of 100% of last year's funding or 105% of last year's funding, and I would say those plans are utterly unrealistic in the environment we're in.
Do you have concerns that a 20 or 30% cut could send some components of the healthcare system in a tailspin if they do it across the board?
The tailspin is the U.S. economy. What happened when the Irish government could not make difficult decisions is that, as Margaret Thatcher said, eventually governments run out of other people's money. And there's a new audience at play that may be as influential as the American people. The American people are by far the most influential, but their decision is only rendered every 2 years in an election. The new audience in play is the creditors of the United States. They are extremely sophisticated. When complicated legislation is put out that claims to do something, they will read every line and find that it hasn't done anything. And the judgments that they render are swift and severe. And so, for example, when the Irish government put out its austerity plan, credit markets looked at that plan and immediately realized it didn't do much of anything. And over one weekend, the Irish government's finances collapsed. And the result was that interest rates went up so quickly that 40% of all family mortgages in Ireland disappeared over one weekend. We need to protect the American people from that kind of judgment, which is why a fiscally conservative policy going forward is not just absolutely required, but is essential to protecting the American people from the kind of fate that is right now befalling families in Ireland, families in Greece, families in Portugal, and now most worryingly, families in Italy.
Well, Senator, let me allow your resident colleagues from Illinois to ask some questions. Questions from the audience?
Senator, you talked about NICE.
Identify your place.
I'm sorry, Paul Handel. I'm a urologist and a fellow of the college.
Right.
You talked about NICE. What is the Senate's attitude towards the Independent Payment Advisory Board and the mischief that can do?
I oppose IPAB. IPAB is our version of NICE, and I think those administering the health care bill would like to give IPAB all of the powers that NICE has and all of the ability to restrict care. And I think the only way that we can avoid those restrictions is laying out a plan for the American people not to depend on the federal taxpayer over time for a growing part of their health care. Actually, I would go in the other direction and have them depend less and less over the next generation so that they're not connected to a bankrupt bureaucracy that then puts forward restrictions that cripple quality of care.
Any other? We have time for one more question from the audience. Well, Senator, yes, introduce yourself, please. Turn your mic on.
Anyway, let me just speak loud because I don't know how to. Turn this on.
Press the button and it turns green. It's on.
And that was really a telling example of what happens if the credit rating, even if they haven't spoken, it's kind of automatic, right? The whole thing collapses. And this is what we are in at this time. Everybody's scared about credit rating. But remember the credit rating that we now have, Moody, S&P, they're the same credit rating that rated the mortgage companies that say they're okay, and yet they collapse. So the question is, how can we trust this credit rating?
I think you can't trust them fully at all, because Moody's, Standard & Poor's, and Fitch all rated mortgage-backed securities at AAA, and they weren't worth anything. And they rate us as AAA. I think they have been burned by the crisis of 2007, 2008. But I think their warnings regarding the U.S. credit rating are well-founded.
Well, Senator, you've been a supporter of the college, and I will predict you're going to have a bright future.
Anyway, thank you all for having me.
So thank you very much. Thank you so much. We'll continue on with the next speaker, panelist, is Dr. Alejandro Perez tomorrow. She is the Chief of Surgery at Mercy Hospital and Medical Center. She applies her teaching to, obviously, the latest minimally invasive surgical procedures that treat breast cancer. She has been a teacher, educator of medical students and residents for a quarter century. She looks like she must have started very young. She obviously addresses trying to eliminate disparities in all aspects of medicine. She's fluent in English and Spanish and has played a significant role, not just in the Hispanic community. I think her influence has transcended ethnic and geographic backgrounds. So without any delay, I would like for would somebody let Dr. Hort know that his microphone is still on.
Talking about the money thing.
Dr. Tomorrow, I want to just thank you and then let you speak, and hopefully that somebody will cut off Dr. Hort's microphone.
Thank you, Dr. Britt. Like Dr. Britt said, I'm Alejandra Perez Tamayo, and I've been the chairman of surgery at Mercy Hospital for 13 years, and I've been surgical attending at Mercy Hospital for a bit over 25. And for those of you that do not know Mercy Hospital, and I don't blame you, it's a small community hospital. It was the oldest hospital in Chicago. It was started by the Sisters of Mercy, and therefore I really feel compelled to introduce Sister Sheila Line, a staunch advocate of access to care, no matter what your ethnicity, economic status is. And it's this unique partnership between Sister Sheila and several of the physician leaders, all private practitioners, that allows Mercy Hospital to be that unique. It also serves as a safety net hospital. And so the reason I'm giving you this introduction is because we count our pennies very closely. We can't afford glossy marketing and a lot of commercials and a website that has all bells and whistles. And as anybody that has gone on the internet, you can find anything on the internet. And what really is true? Well, what is true is something that is measured, that is standard, that can be published, that can be reproduced, and that is followed. And so in 2006, when I started learning a little bit more about the NISQIP program, I did what I think a lot happens between physicians and administration of the hospital. I walked into Sister Sheila's office without an appointment. And I said, Sister, we need to invest in the NISQIP program, and it was Valentine's Day of 2006. And I realized its true value because as a chairman at Mercy Hospital and also as a surgeon champion and actively practicing general surgeon that takes call every 5 weeks, I needed a tool to really see how we measured and how we stacked up against similar community hospitals. And we faced the same challenges that Senator Kirk was mentioning with the rural hospitals, maintaining staff, keeping general surgeons engaged, having great quality surgical care, and having a spectrum of surgical services. And we know the shortage that is oncoming about general surgeons, so with that in mind. And we entered the NSQIP program, and a lot of very good things have come from that. I also failed to mention that we also teach students and residents. And so one of the ongoing things for residents and medical students, they need to know what SCIP means, what the Surgical Care Improvement Program means, what NSQIP means. So I tried to gather what we've achieved through the NSQIP program, and one of the very first things is a dialogue. We established a multidisciplinary program, our meetings, that we would discuss results, and the beauty of it is that we get quarterly results. So rather than having something reacting to something that happened a year ago or maybe 2 years ago, which is many times what we see published in the newspaper or in some of the websites, we get quarterly results. We were very instrumental in educating both residents and students about documentation. That's the first step in any quality program. We found with SCIP that while it involves processes, documentation is a very important thing. We improved in some of the knowledge of our care workers, such as wound classification improvement, and we overall improved on our pulmonary embolism rate, our DVT, deep venous thrombosis rate, and our infection rates. The other challenging thing for Mercy Hospital, because it's a mix of indigent, managed care, and private insurance, was following the patients. And so we were able to improve on our follow-up. And that's just one of the things that NSQIP did for us.
Great. Thank you very much. And our next speaker is from the University of Illinois Medical Center. Dr. Benedetti is the Warren Cole Chair of Surgery, professor and head of the Department of Surgery. He's also the director of the Transplant Center at University of Illinois at Chicago. And as chief of the Division of Transplant for the last 8 years, he's really established a world-class program in liver, kidney, pancreas, and islet cell and small bowel transplantation. And he's going to talk to us from his perspective in one of the academic medical centers in Chicago. Dr. Benedetti.
Is your mic on? There's a green light that comes on. Okay.
It's coming. Great impact on our field of transplantation, which is a centralized monitoring that has, I believe, increased the quality in our field tremendously. It may be an example for other fields. Of course, we are talking about a complex and highly costly field, transplantation. We have a nationwide monitoring system that actually is applied uniformly across the country. And they have been calculated in base on case mix and complexity of the volume, certain parameters that, for example, in kidney transplant result in expected patient and graft survival. We have a database that is shared. The public has free access to information only 6 months old. And if programs fail to live up the expectation, meaning meeting this minimal patient and graft survival, they are first initially warned and then finally shut down. This is actually a very good system in my experience because it has eliminated any program that would perform substandard. The American College of Surgeons is taking leadership in doing the same for Bariatric Center of Excellence. Medicare has done the same for coronary artery bypass graft survival, which are monitored for patient survival, rate of complication, length of hospital stay. I'm suggesting that this central monitor, based on database reporting, based on facts, on appropriate adjustment of risk based on the case mix, may be applied to other fields of medicine, increasing tremendously quality and outcome. I'll choose a small example. We know that carotid endarterectomy is superior to medical therapy for critical stenosis and patients with symptoms, but there is an important issue. If the surgical outcomes are not perfect, and if you have a lot of complications such as perioperative death and strokes, then you lose the advantage. Shouldn't we monitor in this field as we do for transplant, for bariatric surgery, for bypass? I think we should do more and more, especially in specialty that are costly and involve a lot of public opinion, perception, investment from the government. And I would suggest that the colleges should take the leadership to choose the appropriate topic. I don't advocate widespread dissemination application of such stringent criteria, but there are some diseases that, because of this complexity and the cost, should be probably monitored closely. Thank you very much.
Thank you. It gives, Dr. Benedetti, it gives me great pleasure now to introduce a personal friend and a colleague. Dr. Jeff Matthews is the definition of an academic surgeon. He is the current Femester Professor and Chairman of the Department of Surgery at the University of Chicago and Surgeon-in-Chief of the University Hospital. He is an accomplished author. He has a broad interest. His specific interests certainly will concentrate on pancreabiliary and obviously GI surgery. He is the co-editor-in-chief of one of the leading journals in on that topic, the Journal of Gastrointestinal Surgery, and he serves on several editorial boards. He is the past president of the Society of University Surgeons. He's the president-elect of the Society of Surgery of the Alimentary Tract, and I think everyone will say that he's a world expert in his field. And so without any further delay, Dr. Jeff Matthews.
Thanks very much, Dr. Britt and Dr. Hoyt. I'm delighted to be here and to participate in this forum. At the University of Chicago, we have definitely taken the lead in the area of quality, inspired by the work from the American College of Surgeons. Our goal was to create a new culture of surgical quality improvement in our institution that would optimize care and improve efficiencies and lower costs. We endorse and have participated in many of the quality efforts launched by the American College of Surgeons, including the Centers of Excellence programs in surgical oncology, in breast oncology, and in obesity surgery. We, however, were forced to take a very hard look at ourselves back in 2006 when some of the data started coming out from the SCIP project that was mentioned earlier, the Surgical Care Improvement Project, which measures certain core performance standards in terms of prevention of infections, prevention of venous thrombosis and other activities. And we found, to our surprise, that despite our pride on and ability to handle the most challenging cases, that in some of these routine matters we were falling short of our own standards. And that really motivated us to unify around quality, to focus and build the infrastructure at the University of Chicago to create this culture of quality improvement. And within 18 months, we transformed our performance on these measures to achieve 100% compliance and sustain those results on the subsequent 2 years. So this works when you do it in an organization. The problems that we treat at the University of Chicago tend to be more unusual or high risk than many of the programs are able to capture, which focus on more routine, high volume, or otherwise easily benchmarked procedures. So we have been using the NISQIP program to create, to adopt their principles to establish a surgical quality review committee to evaluate the outcomes of particular innovative or complex procedures, to identify opportunities for quality improvement and process improvement, and to measure our performance against the best published measures. So these activities work. They can help us create the kind of infrastructure in our organizations that can achieve results. And based on data, we can move forward and improve surgical quality. Thank you very much.
Thanks, Jeff. It's now my pleasure to introduce Dr. Reynolds. She currently serves as Surgeon-in-Chief and Head of the Department of Surgery at Children's Memorial Hospital in Chicago. She holds the Lydia Frederickson Professorship in Pediatric Surgery as a Professor of Surgery at Northwestern's Feinberg School of Medicine. Her broad range of surgical expertise includes developmental anomalies of the lung, diaphragm, intestines, and abdominal wall, childhood tumors, and extracorporeal membrane oxygenation. Dr. Reynolds is Children's Memorial Hospital's first female surgeon-in-chief and one of only 4 women in the United States serving in this role at a preeminent children's hospital. She was voted one of the top docs in Chicago Magazine in 2010. Dr. Reynolds.
Thank you very much for including me in this very important forum. As you may or may not be aware, pediatric quality measures and outcome studies on a national level are really in their infancy. The phase 1 study for the pediatric NESQIP program has been recently published, and the phase 2 study is coming to completion. Pediatric NESQIP was developed in conjunction with the American Pediatric Surgical Association, which is our national organization for pediatric surgeons, in collaboration, obviously, with the American College. And what makes the pediatric NESQIP program a little bit different is that this program is a multi-specialty program because of the nature of pediatric surgical subspecialties. The group has redefined and modified variables to apply to pediatrics, and it is one of the most important elements about it is that it is risk adjusted. As the national program rolls out early next year, a Children's Memorial Hospital will have an opportunity to participate and to use the data to improve the care that we provide to our patients and to children across the country. In addition, we have had the opportunity over the last several years to work with the American College through their Clinical Scholars Program, and by working with some of the physicians who have participated in this program, we have identified areas across pediatric care that need improvement and opportunities that we can participate in particular the treatment of thyroid cancer and the treatment of Wilms tumor in children. I think that children's hospitals in general are the leaders of the pediatric quality efforts across the country, and I really appreciate Dr. Kirk's comments relative to his support for support of Medicaid, because without it, children's hospitals in the United States will not survive. I really appreciate the opportunity to share our efforts with you.
Thank you, Dr. Reynolds. Our next panelist is also a household name. Dr. Nathaniel Soper is the current Loyola and Edith Davis Professor of and Chairman of the Department of Surgery at Northwestern University and Surgeon-in-Chief of that hospital setting. He has certainly distinguished himself in all aspects of general surgery, particularly in applying the minimally invasive technique to general surgery problems. He is a well-published, he is on the several editorial boards of the major journals, including the Annals and JACS and the World Journal of Surgery. All these panelists are best doctors, so he's on the best doctor list, which must be a long list. But in all fairness, he has lectured throughout the world, and we'll look forward to his comments now.
Thank you very much, Dr. Britt and Dr. Hoyt, for including me in this forum. I think it's really a great opportunity to discuss some of these issues that are so critical to what we do. My Department of Surgery's vision statement reads, safer surgery today, better surgery tomorrow, and that's what we strive for. At Northwestern Medicine, quality of care is kind of the cornerstone of the mission, and we've been involved in quality efforts for a number of years across the street here. We were an early adopter of NSQIP, and we've really used that in our quality improvement programs. But we also knew that a cultural change was really necessary, not only among physicians, but among the staff as well. And so for everybody coming into the OR environment, they need to take part in a team training effort. And that's been going on for several years now. Amy Halverson actually helped lead that program. We are also early adopters of the WHO checklist, the sign-in, sign-out project, all of those things that we try to do to improve safety. We've also had a very rigorous simulation effort, both for skills training for surgical trainees, but also for communication and those sorts of things. Northwestern Medicine as well is very steeped in the Lean Six Sigma terminology and the methods and the DMAIC process, and we've used NSQIP results now in several areas. We were on the right side of that curve for pulmonary embolism and DVT a few years ago, using the DMAIC process. We've knocked that way down, as well as for surgical site infections. In fact, we've seen a 30% decrease in claims over the last 5 years related to surgical care, and I think that's very important. And in fact, we've put in place an anonymous form of reporting system where all healthcare providers can put in near misses or other problems that they see. The number of incidents that have been reported have doubled over the last few years, whereas the number of serious events occurring that then go to malpractice claims has decreased by 80%. So I think you can see how employing technology like NSQIP that is very rigorous, you can measure it in things, and then coupling that with a project whereby you can put in the technology that's used in industry around the world, you can really make headway. And we've been very happy to be partnered with the college in these efforts. Thank you.
Thank you, Dr. Soper.
Thanks, Dr. Soper. We've truly heard from the leadership in surgical care in Chicago and Illinois from this panel, and I want to really thank each and every one of them for taking the time. It's now my pleasure to introduce Cliff Coe. He's the director of the Division of Optimal Patient Care and Research at the American College of Surgeons. And the NSQIP program is certainly one of the premier programs in improving quality, but I also want to point out that there are many other programs that are equally important. Dr. Coe has been instrumental in developing the NSQIP program, which started in the VA system. He currently continues as a practicing surgeon, as professor of surgery at UCLA, but it's really been his dedication to developing the program, developing new versions of it, developing its application to hospitals that it's made so successful. Cliff?
Thanks. Thank you, Dr. Hoyt, and welcome everybody. I'll keep these short with the late hour, but there's a few points I think is summarizing of the great stories that you've heard today and what Senator Kirk has said. That first, the quality landscape is changing. It's getting to the front pages, and we're all working on it as hard as we can, and we have to ensure that as we're working on it, we need to measure in the best way the quality is, because at the end of the day, we have to be able to answer the question, are we in fact better than we were yesterday, than last week, than last year? And we have to know that we absolutely are. I think that most of the physicians in the room know that we are being measured in terms of quality. As folks have measured, there's the Surgical Care Improvement Program, or the SCIP program, that we're currently, all our hospitals are perseverating on to attend to and fix and improve those process measures. But I think that we can do better. I think that we can look at beyond process in some instances and look at outcomes, so that at the end of the day, we know that our patients are doing better in terms of their outcomes, that they are better, that the survival rates are better, that the infection rates are lower, that the thrombosis rates are lower. And so we can do that better, and a lot of our programs will focus on outcomes, and the one that you've heard most about today is NSQIP, which looks at the outcomes and it risks adjusts it. So it takes into account the fact that certain hospitals might have a sicker or more complex patient who might have heart disease or pulmonary disease or kidney disease or whatnot, and takes those into account, and then gives back a point and tells you how you're doing compared to another hospital or compared to all the hospitals that are involved in the program. So that's very important. And I think that the third point is that as we move forward, we really need to do this and focus quality on the things that work. We spend a lot of time doing a lot of things that we find out that might be too simple, that might be on superficial levels okay, but when we look beneath the covers, it doesn't really work as well as we want it to. So we really have to focus on the things that are going to improve care, that are going to decrease burden, that are going to, as Senator Kirk said, decrease the cost, the burden, improve resources, and at the end of the day, improve the care for our patients. As Dr. Hoyt said, we have a lot of programs at the college, NSQIP, and we have a trauma program for verifying that trauma care is done well. We have a cancer program. Dr. Winchester's in the audience, who leads the cancer program, and specifically a breast cancer center program. All of this also is in conjunction with education, and Dr. Sachdev is here in the Division of Education, and the college leads in terms of educating surgeons and hospitals in that regard. So it's a big system altogether, and so I'll just leave it at that. Thank you.
Well, you've heard from everybody on the panel, and I just, again, want to thank each and every one of the panel members for taking the time to come this morning and participate in this. We'd like to now open it up for questions. If there's somebody in the audience that has questions, please feel free to raise your hand. I'm going to start it off, and then I'll turn it over to Dr. Britt. But we've heard a lot from the surgeons about this, and today this is a partnership with hospitals, with hospital administration. So I'd like to ask our surgeon panelists and Dr. Chassin as well, what's the role of the hospital administration in helping improve quality and safety? What are we doing, or what are you doing specifically in your hospital to work with administration to bring about these important tools and this important change? Let's just go right down the row. Mark, if you want to start off.
Sure. Thanks, David. I think the most important first step that any organization can make toward a commitment to much higher levels of quality and safety is for the entire leadership of the organization, hospital, health system, medical group, which includes the governing body, the board, the management of the organization, the physician and nurse leadership, is together to commit to higher levels of quality and safety. And as we've started to articulate what that roadmap looks like to high reliability, where we really expect and achieve 0 major quality failures, that's the first step. Without that kind of commitment in a unified way, we can't really expect the kinds of major cultural changes and major improvement activities to be undertaken. And I think we're starting to see the mobilization of all those leadership constituencies to work together instead of the finger pointing and blaming that was too characteristic of the way we tried to do things in the past.
Well, what about some of the chairs?
Well, I've said, like I said before, we have a very close working relationship with the administration. And it's that leadership, those physicians that basically go to the administration and ask for specific things, you know, and that is a capital investment. And it's the strength of that leadership and the recognition that quality and a standard qualification of that quality becomes so important. And so in my small hospital, we've been successful in that. The things that we find difficult to execute, as the second part of your question, is we'd like to involve all specialties. We'd like to make this NSQIP program more ubiquitous within the whole surgical specialty. And while we are, you know, we do general surgery and we do vascular, we've just entered the multidisciplinary part of NSQIP. And we're looking at that, but even beyond that, we'd like to have it cover everything in surgery if possible.
Let me, I'm sorry.
I was going to add, the hospital administration supports these efforts in theory. The problem is that they are bombarded with requests. So implementing electronic health records may be $30, $40, $50, $60 million of capital that may be demanded on them. The databases that are involved, NSQIP and dozens of others from other specialties, require capital investments and new people. Transplant databases, $500,000 to $1 million of investment to get them going. At times when the economics of hospitals are so challenging, the administrators have trouble selecting and prioritizing which programs to enter when. And so they understand the role of these quality programs in improving outcomes, but they are challenged to be the sole payers for that and looking for partnerships with other organizations, regulatory agencies, payers and so forth, to be really partners in this is the critical problem that they face.
Well, you hit a very good point, because my job as president is to represent the entire community, which is 78,000 members, looking at really representing 240,000 surgeons. What community surgeons tell me, they're saying that some of these initiatives, while they are good, are unfunded mandates that they can't afford. Some of these smaller most of the hospitals are less than 150 beds. They're saying they're financially challenged to even get into the process of these quality initiatives. I would like some of my astute colleagues on the panel to address this legitimate concern. And I guess I would choose Dr. Chassin because he's the head of the Joint Commission.
Well, I think you've identified a very important barrier to spreading what we know works. And what we've done with this new Center for Transforming Healthcare at the Joint Commission is to take advantage of the hard wiring that we have to 19,000 accredited organizations to make the learnings from the center easily available through very easy-to-use web-based tools that don't entail any additional cost to the organization, whether it's an ambulatory surgery center or hospital, small, medium, or large, that allows them to walk through the steps that the pioneering organizations that created the learning went through, but with very simple jargon-removed steps that lead them to a customized set of interventions that will solve the problems that they bring to the center's solution tools. So that's one of the ways that we're working to address that very important and critical barrier to spread that you mentioned.
Anyone else on the panel? Dr. Coe?
Yes, so Dr. Britt, you bring up a tremendously important point, and that's and I think it echoes what you said earlier about disparities in terms of the various types, the huge variation in types of hospitals that and for this form of that perform surgery in the United States. Almost half of the hospitals in the United States have less than 100 beds. About 1,200 hospitals in the United States are critical access, so 25 beds or less. And they're performing surgery. And so we have to ensure that the quality of surgery is good in those hospitals and in all of our hospitals, and from the largest to the smallest hospitals. And so I know that we spent a lot of time in the college developing programs specific for a lot of these smaller hospitals. For example, in NISQIP, we've developed a small and rural option in the program that decreases the resources needed by these hospitals, yet gives them back risk-adjusted outcomes so that they too can benchmark their care against other small rural hospitals, or they can benchmark their infection rate against all of our hospitals here on the panel. So things have to be focused towards the users, and the small rural hospitals are definitely a group that need to be included in that in what we do.
Dr. Hoyt, I see you got a question from the audience.
The question is, if healthcare is 70% of the gross domestic product, what percentage of all healthcare dollars go to surgical care?
And I particularly want to emphasize this. I mean, people get on the surgeons, but you have administrators throughout the country. Some administrators are very small hospital consortiums making $6.5 million. So some of the money is not necessarily going towards the surgical care when people talk about healthcare expenditures. So I would like for somebody to address that too.
Anybody want to take that on?
I know it's a tough question, but you all are the experts. So,
Dr. Hoyt, yeah, let me take a piece of that if I may. Paul Handel, I'm going to put on my payer hat now. I'm with Healthcare Service Corporation here in Chicago. You would know us better as Blue Cross Blue Shield of Illinois, Texas, New Mexico, and Oklahoma. Couple of points. First and foremost, the healthcare expenditure for the GDP is somewhere around 18% right now. Half of that chases preventable chronic diseases, and we're not doing a thing about that either as a college, the American Medical Association, other organizations. Come back to a point that Dr. Soper made and Mark Chassin, I'm surprised, didn't. Let's go after the simple, cheap stuff first. Why are we not doing the WHO checklist, which we know reduces complications, wrong site surgery, etc. And Mark, I'd like you to talk to the problem you're having in getting hospital personnel and doctors to wash their hands. Simple, cheap stuff that doesn't require a huge commitment in technology that would begin to make a difference today.
Okay, Mark, and then I guess Nat, maybe you should comment as well. Just before you do, though, I think if you look at Medicare spending, that surgical care as a portion of that has been flat over the last 10 years in terms of expenditure growth. The majority of increase in terms of Part B expenditure, which is professional fee, has been in imaging, has been in new diagnostics, has been in increased drug costs, but not per se in surgical care. Mark?
And full disclosure, I can't answer the question of what percentage of our healthcare spending is related to surgical care. I think it's actually a more difficult question than would appear on the surface, depending on how you count. Our experience with a number of these problems that are seemingly on the surface very simple, like why can't we get all healthcare workers to wash their hands when they should? Why can't we eradicate, not just reduce, but eradicate circumstances where the wrong patient gets a procedure intended for somebody else or the wrong body part is operated on? That those circumstances actually turn out to be much more complicated when you look deeply into why they occur than we had previously thought. And one simple answer won't work. So what our center is doing, through the same kinds of tools that Dr. Soper mentioned, of the new industrial improvement tools, Lean, Six Sigma, et cetera, is to look very hard at why these problems occur. What we found very briefly is that the causes differ from one place to another. So the same program that might work to improve hand hygiene at one place will have only a modest effect somewhere else because the causes are different. In the surgical first project we did, for example, in wrong site surgery, we looked at all the points along the way from the scheduling process all the way through to the operating room where the risk of a wrong site surgery is introduced. And they are myriad, and the percentage of cases in which those risks occur is very high. Focused, targeted interventions to get rid of those risks is the answer to this problem, but they need to be customized and they need to be carefully introduced. The other point I would make is that we have the capacity with these process improvement tools to get the waste out of healthcare processes that don't contribute to quality one way or the other, and free up resources that we can use to invest in these new quality solutions. And I think from a strategic standpoint, that's where healthcare organizations need to focus.
Well, why don't we ask the chairs to respond to that too? Just why can't you get people to wash their hands?
Well, I'd like to say that I've been looking at this for 25 years, and I think it's an evolutionary process. It's not about getting people to wash their hands. A lot of these parameters is about documentation. We looked at the SCIP project, and it was supposed to halve infection rates, correct? But it didn't. And so the processes are coming into effect slowly. There used to be a collective conscience. Now there isn't anymore. Now what we have to do is document what we do. When we saw that our DVT rate or our DVT prophylaxis was not as good as it should be, it's not so much that people were being mistreated or not treated correctly in the hospital, but we just had certain parameters that we weren't documenting. So you have to start somewhere. And the change can't happen today or tomorrow. And the first step, and I believe it with my whole heart and soul, is a standardized way of documenting these processes. And it's not just NSQIP. It's the Commission on Cancer. It's your tumor registry. It's what stages your cancers are coming in, and do you have a multidisciplinary approach to them? What are your results? I mean, it's all of this data that we as surgeons, I believe, have gotten late into that process. We didn't start getting computerized until recently. Most of the industries, banking, insurance, they've had computers and automation for years before we did. And so now we're starting to discover how we can document these processes and even take a snapshot of where we are. So I think that we are very hard on ourselves with all of this, nobody hand washes. They do, and they have secret shoppers in the hospital now taking a look and seeing, what services are doing it, and we do need to improve. And we do need to become aware of that. But I still believe the first step is the documentation and taking a real snapshot at what each institution has and how we can improve that.
Dr. Soper, you look like you're ready to answer and respond to.
Well, again, it's not a simple thing. Most of this really, I think, is culture. But you also need to have buy-in from all levels of the medical system. And so for hand washing, if somebody was observed not hand washing going into a patient's room, they would go to the CMO's office the next day for a very quiet meeting. And it's that sort of thing that I think ultimately we need to do. We need to hold one another accountable for this. For every critical event that happens, a sentinel event, we have a huddle by all the leadership of both the hospital and the faculty get together and talk about the event. If it's truly a critical event, we have a root cause analysis that goes on. Those things are not expensive to do, but the process of sitting down and talking about what went on, bringing the people in who were actually involved within 48 hours of the event, talking it through, and then deciding how things can be changed to prevent those things, I think, again, needs to be brought in and really brought into the culture of the organization, and that's how we can do it.
I'm going to get Dr. Reynolds in on this one because I think the elephant in the room, in my opinion, I'm not speaking for the college, this is LD Britt speaking. The elephant in the room is health literacy. If you look at the Americans, you have 90 million Americans not following simple recommendations. So something is lost in translation. So health literacy is key, but not many people talk about that. And you have a special population of pediatric patients. So what do we do to enhance health literacy? Because we can have the best systems out there, but if the patients are not interpreting it and translating it and obviously accepting the recommendations, is all for naught. So Dr. Reynolds, I'm going to let you put your head on as a leader of a special population.
Well, and as a children's advocate, I think it is critical that we continue to provide primary care in the form of pediatricians and family physicians in order to make sure that every child has a medical home. And if children have a medical home and their primary care provider can then educate them about their immunizations and all kinds of health prevention strategies, then we can elevate the care of the children in the United States. I think what I referred to before is really so critical is the fact that, as you know very well, right now, on the current budget, there is no money provided for GME funding for pediatrics. So the United States has decided that educating the future pediatricians of our country is not necessary. And this is just unconscionable. And we have got to provide funds to take care of our children. And I think that's the way you have to provide the funds to get pediatricians on board and produce the next population of pediatricians for our country.
How about some questions from the audience?
We have one or 2 minutes, right? We have 1 or 2 minutes, and again, you all are here.
I won't be bashful about asking somebody to ask a question.
And I have some questions if you don't, but I would like to hear from the audience. Use that green light, is that green light on? Okay, fair enough.
Green light is on. Thank you very much. No, I know. Okay. Dr. Kirk, you mentioned, can you hear me?
I can't hear you, but somebody will translate for me.
Yeah. Let me just add up. Dr. Kirk mentioned something that's so important, is green, that the reimbursement for surgeons is flat for the last 10 years. It's very important information. And when other payment systems for other specialties go up, it affects also the surgeon's reimbursement because resources are finite. Now, if you enlarge that concept whereby all healthcare payments have contributions from others aside from physician payment, which is hospital, drug companies, device companies. In other words, all of us will be affected from the payment side. But look at this. From the payment side of physicians, we are valuated. There's a valuation of our product, which is RBRVS, SGR, and all of that. And that's why the payment entities can negotiate on the basis of our costs. Our cost is RBRVS. It's not on our price. In other words, we have a $1 cost. We price it at $100. We will not be paid because payment entities know our cost. So they can pay us maybe $2 or $3. But the reason why it's so important is other producers of the product, other providers, hospital, health insurance and others, drug companies and others, the payment entities do not know their costs, so they negotiate on price. In other words, if I, as a pharmaceutical company, price it as $100, but my cost is not known, but actually it's $1, I will be paid $50, and of course I'll be happy. But for physicians, it's different. The point I'm driving at is...
What's your question?
The point I'm driving at is there is a disparity in the way primary producers, which is us, physicians, are being evaluated as to the payment system that we have, whereas others are not. That's the point.
Okay.
Yeah, well, I think, you know, those are very important points. The thing that I think you heard Senator Kirk emphasize is reality, is that the national debt crisis is really driving a lot of this. And if you accept the fact that we have to contribute something to help that, the most important thing we can contribute is to take the unnecessary costs out of the system. So the strategy of reducing complications will free up dollars to then pay for the care, which is in line with what you're talking about. So the reason we're emphasizing this is this is something real that we as providers, while looking at for our own self-interest, we can bring to the table that overall helps all of these issues, disparity and cost reduction.
You bring up a good point, because I can tell you right now, you look at the dollars being spent. I want them to look at some of the fraud in Medicare, there's $80 billion. I want them to look at some of the high, exorbitant administrative fees with CEOs. They need to look there too. And so I agree with you. I think our time, Dr. Hoyt?
Well, our time is up, Dr. Britt, and to close, we need to close with our video. So before we show that, which I think you'll find inspiring and really tries to bring together everything we've been talking about, I really want to stop for a moment to thank our leaders in surgery in Chicago for participating. I want to thank all the participants for showing up as well. And again, I just want to thank our staff, both inside the college and those that we work with at Weber Shandwick, led by Nancy Longley, but in particular also Lynn Meyer and her staff for the contribution for putting the event together today. Now, the video here requires you to take your stress cube, which is in front of you, and hold on to it. And as you respond emotionally to the video, you will then have a way to deal with that. Okay. There we go. Again, thanks to everybody for coming today.